It's December 8th, 2023, and this is the RheumNow podcast. Hi, I'm Dr. Jack Cush, executive editor of RheumNow.com. Thank you for joining the podcast. You know, this podcast is brought to you by RheumNow Live 2024. It's fast approaching January 27 and 28. It's going to be in Dallas, Texas, a mere 5 minutes from the airport. Great location at the Westin Hotel. This meeting is co-hosted by myself and Artie Kavanaugh. We think it's the best meeting in rheumatology. We hope that you'll attend. You know, I look at this week's podcast, I'm sort of amazed at how multidisciplinary rheumatologists are. Today we're going to talk about where rheumatology intersects with cancer, with obesity and bariatric surgery, with neurologic diseases, with vasculitis, with pain, epidemiology, and we're going to begin with reports from the derm world, specifically two reports from this week's JAMA Dermatology on topics that we kind of see. The first one is palmoplantar pustulosis. This is a difficult subset of patients. Even the derms break out in hives when they get patients with this because, you know, they have got great therapies for psoriasis, do they not? But these are kind of resistant. We have some indication. Actually, we heard last year at RheumNow Live from Ken Gordon telling us that the scoop was that JAK inhibitors look really, really good at treating palmoplantar pustulosis. And better, again, there are no studies head-to-head and whatnot, but the consensus opinion from uncontrolled observations was that JAK inhibitors look to be better than, for instance, TNF inhibitors and maybe even, 1223 inhibitors. But nonetheless, this week's report actually talks about 21 patients who were treated with open-label bimekizumab, the new IL-17A/F inhibitor, and 17 out of the 21 had complete clearance of palmoplantar pustulosis in as little as 1 month and as much as 4 months. Some of those patients had SAPHO, and they did very well with complete clearance of skin and improved joint symptoms. So I think that's encouraging until we can get a good study on this, and those are hard patients to study. There aren't as many of them. We're left with anecdotalism, are we not? Or, you know, and sometimes the worst thing you can do is go by anecdotes, or even worse, go by, you know, large cohort registries that compile data that's observational. So we really do need clinical trials here, do we not? Another report from JAMA Derm talked about the incidence of paradoxical reactions with biologics. Now, we are very familiar with paradoxical psoriasis in patients getting TNF inhibitors, and then they've also had paradoxical colitis and sarcoidosis and eye disease. Well, in this particular report of almost 14,000 psoriasis patients on biologics, they found a 1% risk of paradoxical eczema. Now you're irritated. Why am I bothering you with a 1% risk of eczema, which you couldn't tell from a sunburn? Well, you need to know, because your patients may find this. And I find this kind of report interesting but bothersome because, A, it comes from the derm world, where they're likely to see derm things more so than you and I. Second, patients with skin disorders get more skin disorders. So is this real or imaginary? The risk factors here were age and having a prior history of atopic disease. Well, they already had atopic disease. Anyway, 1% risk. This was lowest with the IL-23 inhibitors, 0.56 events per 100,000 patient years. Higher with IL-17 inhibitors, 1.2 per 100,000 patient years. Maybe you're turning off this podcast at this point. Wait, stick in there. There's more, including the next two I think you're going to love. PLOS1 is a journal, online journal. They published the results of a systematic review, only 3 studies, but nonetheless, a consistent story. 6,700 RA patients undergoing bariatric surgery or not. And when they looked at disease activity, they showed a significant reduction in disease activity at 12 months with bariatric surgery compared to those who didn't. And it dropped by over 55%. Same thing for reduced comorbidities, dropped by 55%. Turns out that BMI at baseline and the BMI after bariatric surgery was significantly reduced. It went down from a 43 to a almost less than 30. So that was a significant weight drop in this 12-month analysis. Now, really, the question, of course, is with bariatric surgery is are the sleeves better than the the Roux-en-Ys and the other types of surgery you can do, and does it last? Those are the big questions I always have with this. I think patients who are morbidly obese, it gets in the way of drug choices, drug responsiveness, outcomes, all kinds of things, and sometimes that may be a smart choice. And this data would suggest it. There isn't a lot of good studies that actually have looked at this, but this is 6,700 patients. I think that's important. Another study coming from a registry in Kuwait looked at the relationship between RA activity and uric acid levels. Now, there's an inverse relationship, right, between RA and gout. So it's sort of like, if your primary care is confused, tell them look at the rheumatoid factor, look at the uric acid, and figure it out that way, because you don't usually get both. And this study kind of confirms that, because they had this very large cohort, 1,000 plus RA patients who had measurements for uric acid. And in that cohort, 15% had high uric acids. If you looked at the relationship between uric acid level and disease activity as measured by -28, it was a significant inverse relationship with a p-value of 0.3. Odds ratio 1.39, meaning if you had a high uric acid, you were likely to be in low disease activity state or in remission. Nonetheless, even though that high disease activity was always seen with low uric acids or the inverse, high uric acid levels were associated with higher HAQ scores. So maybe whatever's driving that, they didn't talk about whether there was an incidence of background gout here or not. That wasn't in the study. I imagine it wasn't collected as part of the registry. But it does support the idea that you often will not see gout in association with RA, although you and I are the exceptions. We've seen these cases and sometimes have to manage them. Two good reports on fibromyalgia that you really need to take note of. One comes from Arthritis and Rheumatology. A randomized controlled trial of cognitive behavioral therapy was done, 114 fibromyalgia patients, and you know what? It didn't really do all that much. Oh, wait. No, it did. Significant reduction in pain catastrophizing, pain interference, I'm not sure what that is, and also improved function. This was had a neuroimaging component, and they showed that when cognitive behavioral therapy was done, and 98 of the 114 had neuroimaging, they showed comparable improvement in brain imaging in the certain areas of the brain associated with these particular measures of pain, catastrophizing, etc. So it gives you a nice sort of physiologic and anatomic correlate to the psychologic intervention, which we know does work in fibromyalgia. So CBT, we probably don't use enough of it. You should probably work hard at finding who does CBT for fibromyalgia in where you practice. So that's good. That works. You know what doesn't work? Naltrexone. I don't know if you're getting these requests for naltrexone in our patients, and not just in fibromyalgia. There's a lot of voodoo going on about naltrexone. It's being, I guess, promulgated by pain specialists. I'm not really too certain about this, but this was a placebo-controlled blinded trial of 99 fibromyalgia patients. I think it was a 2-to-1 randomization. Pain decreased 1.3 points on naltrexone and only 0.9 on placebo, and that was not significant. Discontinuation rates were 6 to 8%, not different between the two of them. They did suggest that maybe those on naltrexone may improve their memory problems, and again, I don't think that was not an intentional, extensive part of their investigation. My interpretation of that is maybe naltrexone improves the sleep. while it may help pain in a few people. But anyway, it was not significant. It wasn't a primary endpoint. It certainly would not be enough for me to use naltrexone in patients with fibromyalgia. And the ones, frankly, who've come to me asking for naltrexone, I say, I don't prescribe it. I send patients to the pain doctors and let them play with that, because I am unaware of its efficacy. And now you are aware of its lack of efficacy. I like this report about the epidemiology of rare diseases in Poland. So in Poland, they found in their population 78,000 patients with sarcoidosis, 3,300 with Still's disease, 35.5 thousand with systemic sclerosis. In a study of patients between 2009 and 2018, which do you think had more hospitalizations between sarcoid, Still's, and systemic sclerosis? Well, the lowest was sarcoidosis at 5.4 days per year. Next in the middle was 6.2 scleroderma, and most likely to be hospitalized was Still's disease, 7.44. Again, that's the annual average per, for the patient group. And what's my take on this? My take on this is that, my job is to keep my patients out of the hospital. So if scleroderma is managed by me, it's not going to end up in the hospital. If sarcoid is managed by me or a lung doctor, it's probably not going to end up in the hospital. Still's disease ends up getting managed by everybody but you until the diagnosis is made. So they often end up in the hospital, and I think that that's what is being reflected here. Interestingly, in 2008, the Still's hospitalization rate was almost 12, and it went down to 5.8 by 2014. So obviously, better awareness has resulted in less hospitalizations. You're certainly aware of the difficult to treat RA rules and guidelines and definitions set up by EULAR, and that has resulted in new research that's going to investigate what characterizes difficult to treat RA and how to best treat those patients. This is now being extended to other disorders, including psoriatic arthritis, and now in this report, patients with axial spondyloarthritis. So in a study of 311 axial spondyloarthritis patients, 88 were characterized as difficult to treat AxSpa. They said that, in a definition they kind of lifted from EULAR and RA, it was failure of two or more biologic or targeted synthetic DMARDs. They said you had very difficult to treat if you achieved that endpoint within 2 years of therapy. So what they found was that the difficult to treat AxSpa patients had more peripheral arthritis, 35% versus 21%. They had higher BASDAI score, not gigantically so, 64 versus 59, and they certainly had more fibromyalgia, and that seems to be a common denominator across many of these difficult to treat studies. Interestingly, the very fast difficult to treat patients had more CRP, more IBD, and no fibromyalgia. So getting there quickly with bad disease, I guess you should be looking for IBD, especially if they have a high CRP. The Annals of Rheumatic Disease published this just recently in their last issue, the results of the 2023 EULAR PMR referral guidelines. This comes from the International GCA and PMR study group. This was, they got a consensus task force. They came together, an iterative process. They came up with 2 overarching statements and 5 guideline recommendations. The guidelines recommendations are: number 1, if the patients are suspected or diagnosed with PMR, that the doctor doing that should consider a rheumatologic referral and evaluation. Second, that those who are diagnosing PMR should do a full history, physical, and laboratory evaluation and then refer the patient to expedite the referral process and to help the patient along. 3, patients with severe PMR symptoms should be considered for rapid access clinics. Rapid access PMR clinics do exist in the UK and in several areas throughout the EU that I'm aware of. They're dedicated clinics where it's easier to get in because there's a significant problem with PMR referrals getting into a rheumatologist worldwide. This is sort of takes care of that problem, except there's just not enough of them. And this practice or this kind of concept hasn't caught on here in the United States. I don't believe it exists in Canada. 4 is that if you are seeing a patient, you should defer, and you think they have a PMR. It's best to defer the use of steroids, especially if you can get them into a rapid access clinic. If you can't get them into a rapid access clinic, then obviously you have to go ahead and treat and then refer and then work on getting them seen as soon as possible. The last guideline was that a PMR patient who has a good response to steroids and is stable and well controlled can be managed by and referred back to the primary care physician and does not need to be managed by the rheumatologist. We can't manage, in the United States, there's either 200 or 800,000 PMR patients. We can't manage all of them, and we're going to need to have a cooperation like what goes on in England in the co-management of PMR patients. This week I was interested in, again, the hepatitis B story, and whether or not you're going to get reactivation if you use a biologic. I'm going to remind you that you assess the hepatitis B serologies, active infection are patients who are hepatitis B surface antigen positive. And the rest is sort of meaningless if they're surface antigen positive. You don't want to give those patients biologics. You want to treat the active Hep B infection, and then when they're controlled, then you can do what you need to do. A resolved infection are those who are B surface antigen negative, but core antibody positive. And then the key decision is whether or not they have surface antibody. If you vaccinate them, they're going to have surface antibody. If they've been exposed, they may have surface antibody. So patient who's B surface antigen negative, core antibody positive, that's a resolved infection. And if they're B surface antibody positive, they're sort of immune and unlikely to reactivate. If they are B surface antibody negative, there is the chance that they could reactivate. If patients who are, again, B surface antigen negative, core antibody positive, and B surface antibody negative, it could be a number of things, right? It doesn't have to be, it could be resolved infection. It could be a occult infection that's more likely to, in fact, reactivate, and another category called chronic hepatitis. So again, I think the point of this is you need to worry about patients who are surface antibody negative as far as reactivation. So I did all this as a pretext to the next report that came out of Korea, which basically said, what is the risk of reactivation with a TNF for biologics if you are, again, a resolved infection? B surface antigen negative, core antibody positive, and in their study, B surface antibody positive. In the rest of the world, and my other reports to you, it's been 2%. And that's kind of a good solid number. It could happen. You got to worry about it. You got to follow LFTs. And if you're concerned about it, get the hepatologist involved. But in an endemic area like Korea, much higher rates, their rate of Hep B reactivation in 416 patients with that profile of resolved infection was 3.5% at 5 years, 6.1% at 10 years, and 24% at 17 years. So you got to worry, especially if they're from an endemic area or you're practicing an endemic area. The last report is, when you tweeted about it last week, I didn't write about it because I wanted to see if the literature was going to change. And that was the FDA warning that came about in the last week in November on CAR T-cell therapy. As you know, this is kind of popular right now with the great reports from Germany about CAR T-cell therapy in a cohort of lupus patients giving tremendous remission in very difficult cases. It's being used maybe in a few other autoimmune diseases, including, and this is CD19 CAR T-cell therapy. It's being used in a few other disorders like the antisynthetase syndrome and being considered for scleroderma, etc. Well, the FDA came out with a warning basically saying that either the BCMA, the B-cell maturation antigen, or the CD19 directed CAR T-cell therapies has been associated with the occurrence of malignancies. Now, the interesting thing, of course, is you choose your CAR T-cell therapy, and rheumatology, we're choosing CD19 on B cells. In oncology, the CAR T-cell therapies are approved and being used to treat malignancies, and that's why they use the BCMA directed CAR T-cells, because that's expressed on normal B cells, but also malignant B cells, and these therapies work, and they have like 5 approved therapies, but they have had reports of CAR T-cell lymphomas. And so the FDA is investigating this. Right now, they're saying that the benefit outweighs the risk, but further study is needed. These CAR T-cell therapies are instrumental in the management of leukemia, lymphoma, and myeloma, and they're largely being used in the worst patients, those who are refractory to otherwise, normal chemotherapies and radiation, etc. We in rheumatology are going to be concerned about this because of its potential use in lupus and other autoimmune disorders. I want you to, again, know that thus far there are no reports of secondary malignancies with CD19 CAR T-cell therapy that I'm aware of, but we're going to watch the literature going forward. So that's it for this week on the podcast. Again, RheumNow Live. This is the last week of reduced registration. It's a bargain. You have until next week, this December 15th. And if you are registering and you're going to Dallas, as you should, Artie and I would love to meet with you. You get your hotel before January 5th because the rates go up after January 5th. I want to reiterate that this is not just a great rheumatology conference with the best of speakers and these TED Talks that we do, but this is a great board review course. I mean, think about it. We are having state-of-the-art lectures and updates in RA, lupus, psoriatic arthritis, axial spondyloarthritis, and vasculitis. We have a lot of TED Talks on myositis and gout and a lot of other things. That, in addition to world-class faculty, now's the time to register for RheumNow Live in Dallas, January 27 and 28. Be there, be square. Have a good week.